not dead, but we still love them. Careful with that information, how you disseminate that. All right, let's jump back in. Hypersomnolence. How many of y'all went and looked up all 7 names of the dwarfs? Or you already know this? Bachelor, dark, filthy, grumpy, happy, sleep, sneezy, and sleepy. Hypersomnolence. This is not due to lack of sleep. This is autonomic behavior in the crowd, as we're so familiar with, can do things in your sleep. So excessive sleepiness with deteriorated wakefulness. Deteriorated wakefulness. So you sleep a lot and it's hard to stay awake. Sleeping all the time. You may experience that autonomic behavior that we said. So familiar with, you can do it in your sleep automatically. Remodeling your bathroom, shopping online, driving to the grocery store, all those things that happen and you don't remember it. And people say, yeah. Some of y'all came up to me yesterday and told stories of people that you know, watch them do this and they don't remember doing this. But it's a real deal. With the meds, without the meds, hypersomnolence, you can do this without the meds. Long naps, still sleeping. This is sleepiness over time versus sudden sleep attacks, which we'll talk about in a minute. This is sleepiness over time. So you got to get at least 7 hours of sleep, the patient, and have one of the followings. And here are the 3s again, the sleep. 3 days a week, 3 months, and the sleep diagnosis there. Recurrent periods of sleep in a day, so lots of naps. Prolonged restorative sleep, if you go over 9 hours, you still have it, that counts as the 1 extra. And then difficulty being fully awake. Takes you a long time, takes the patient a long time to wake up. They're not good for anything. You can't trust them when you wake them up because they're still groggy, right? Trying to wake up a long time. What could cause that? Not just hypersomnolence, but what else could cause that? Sleep apnea. Good. What else that we've already talked about in other lectures? Meds. Yeah. What if they're on meds? Too much med. Yeah. Sometimes you give people half a Benadryl and they wake up like that. Well, what if you have too much trazodone? They wake up groggy. Could be meds. So we want to rule out organic etiology, right? Not associated with another substance abuse or disorder. Clinically significant. They're seeing you. There's the pink box. What do we do for it? Sleep hygiene counseling. We want to clean that up first. And sleep hygiene, there's a ton of stuff. You Google that, there's a ton of recommendations. What are some recommendations for sleep hygiene? What's good sleep hygiene consist of? Screens off, 30 minutes before you go to bed. Yep. Yep. Stop the caffeine way before. Yep. Beds only for sleep and sex. Nothing else. Don't study in the bed. Don't watch TV in the bed. Yep. Go to sleep. And more importantly, wake up at the same time. You can add some finer point on it. You're exactly right. If you wake up at the same time every day, then your circadian rhythm, your body gets used to that, and that helps set your body clock. Good. What else?
Hot shower, 1 hour.
Hot shower, 1 hour beforehand. Yep. Tell the body, relax. A lot of things, right? That list gets long. That list gets long. No blue lights, right? Natural lighting. If you can't fall asleep, get up, get out of the bed, go to another part of the house with that natural low lighting, do something boring until you get sleepy, then go back to bed. So they don't associate the bed with, oh, now I'm going to go toss and turn for 2 hours in that thing. You don't want to associate with that. You want to get up out of the bed. If you can't sleep, go do something boring in that non-blue light environment. That's another suggestion you can counsel your patients on. A lot more of those things. You'll get good at it. Sleep hygiene, which is a form of good. And we want to make sure they're safe. Sleep med referral to rule out other things if other things are going on. Good. Narcolepsy. Irrepressible sleep. Sleep attack. So this is the sleep attack. Narcolepsy. Plus one of the following. Kind of place. I had a friend who was telling me this story, and I said, no, this can't be true. But he was saying he got married in a small town, East Texas, and his cake maker that for their wedding is narcoleptic. And I thought, the vision that came in my head was, how many half-made cakes are in the back with a face print? Well, he said his wife and his mother-in-law went to meet with him, and they'd be sitting in chairs with a desk, and the cake maker was on the other side, and talking about what's going on, and then the guy was just going. And then after a little bit, he probably set up, they continued the conversation right where it left off, and they, okay, I guess we're keeping going. And then at one time, he nodded off and stayed down for a while, and they thought, should we leave? Should we wake him up? I don't know what's going on. And then he finally woke up, and he was groggy, and you had to remind him what he was talking about. I laughed so hard. How many half-baked cakes with face prints in the back? Narcolepsy. Narcolepsy plus one. Now this is a lab. This is one of the few times I'm going to in psych say we got to order a lab. You got to know what it is. Hypocretin deficiency is one of those. Is measured from CSF. So that if we get that back, that's an objective measure to say narcolepsy is present. If you have irrepressible sleep and low hypocretin, then you got narcolepsy. You got to have one of those three. So the first one, cataplexy, is you think about fainting goats. You ever seen that? It's worth a Google. Watching those videos. You scare a goat and it just stiffens up and falls over. Cataplexy is very similar to that, but except instead of stiffening up, relax. So you just relax and faint. So you lose control of the body. So somebody who just falls over, that's cataplexy. Now, when someone has cataplexy, they not necessarily are asleep. So they could be and appear to be asleep. And if you see parents and they know their kids have narcolepsy and cataplexy, and they've done this a while, and they fall down, and so the parent just stands there and watches them for a while, and then they wake up because they're in the park, or on the sidewalk. Instead of getting them up and carrying them somewhere, they just let them sleep for that, however long it is. But cataplexy is that collapse or that fainting, as you say, from somebody. If that's present with irrepressible sleep, that's enough to say narcolepsy. I say cataplexy doesn't mean they're unconscious. Sometimes cataplexy is they're very aware and can hear their surroundings, and so be careful when you talk about a person with cataplexy, because they might not be asleep and they hear anything. So this is remaining and practicing that professional demeanor. So you walk into a room and you think the patient's asleep, and you say stuff, it's not good, they could be hearing that. You see that on a comment card, and that could come back to hurt you. So be professional all the time. You don't have to worry about it. The third thing, along one of the options as far as accompanying irrepressible sleep for the diagnosis of narcolepsy is PSG, soft polysomnography or sleep study. If you have AHI, REM sleep latency less than 15 minutes. It usually takes about 30 to 45 minutes to get into REM, so that'll give you kind of some context. So that REM on a sleep study is 15 or less minutes. They're getting the deep sleep real quick. That is enough to say narcolepsy. So one of those three at least, along with irrepressible sleep, and that's narcolepsy. This is pretty cool. They have British accents, which makes it sound smarter too. So if you, is that in y'all slides? You got that? Okay. Worth watching, and you can see she just kind of nods off sometimes. Worth seeing what it looks like, and to see how limiting it is for a person. You think this person's safe to drive? No, that'd be a bad day if they did this behind the wheel, both for them and other people too. So that's something that's where you can step in and protect them from themselves and other people. But this person, kind of, you feel that, but this person's limiting their life. There's a big box for narcolepsy. What do we give for it? Why don't we counsel this person? Why isn't that first on the list? Say again? That's right, they can't hear it because they're asleep. That's funny. Maybe, if they just have counseling. No, that sounds good. No, this is an objective thing, right? We got a lab for it, we got a sleep study for it, and this happens without there's no psychiatric component necessarily or convincing them to do better. So there's no counseling that goes along with this for the narcolepsy itself. There could be other things going on, right? But this one is, we give them a stimulant. We wake them up. We give that med so they stay awake, and it helps to fight that irrepressible sleep attacks in that. So this is modafinil. We've already, or this may be the first time y'all seen this med ever? Provigil? Modafinil? Okay. So it's a stimulant. This is a go pill. So if you ever got go pills, your mission required that deployed, you get a handful of those. This is a accountability item, so you have to come back with the same amount that you gave, or else you have a 06 or higher authorization to take this on your mission. And you gotta have that piece of paper when you turn those 3 left back in, so that they don't say, you've been selling this on the street, because that's how dangerous this drug is, addictive, street value of this drug is, it's a stimulant. So think cocaine, modafinil, same category as far as badness that could happen, but somebody who has narcolepsy is a good thing, and it helps them work for them. Methylphenidates, what do we think about that? Remember where we used that one? ADHD in particular, which demographic? Children, yeah. It's a little less potent, and so children usually respond to that one, and we like lower dose, that lowest effective dose for kids especially. So that's another one, and then amphetamines is last on the list. So, and if methylphenidates don't work, then amphetamines will jump to that. Last on the list there. There we go from our med slide. Pull that in. Here's some modafinil. So that we have seen before on our list. Good. That's treatment for narcolepsy. Next, OSA stands for obstructive sleep apnea. Remember, central sleep apnea. What's the problem there? Respiratory what? Yes. Effort. Yes, respiratory effort, central sleep apnea. And so then obstructive sleep apnea is, what's the problem there? It's a blockage, something blocking it. So we'll talk about what that is. Good. And CPAP, we're talking, it's mentioned right here. Anybody know what CPAP stands for? Constant positive air pressure. Yep, good. That's a machine used to treat OSA. You wear a mask with it, and you have all kinds of different versions of it. You may have to coach them up and say, try a different one. Don't give up on the first one. But that sometimes makes a world of difference. A lot of times it does. We'll talk about that. So OSA, distilled out of the pink box. We talk about OSA a lot. You'll hear that, obstructive sleep apnea. It's the most common breathing-related sleep disorder. And so when you get that sleep study, that PSG, polysomnography, and you get back somebody who has sleep symptom, what would be a sleep symptom for OSA? What do you think? Obstruction. What would clue you into obstruction while they sleep? Periods of apnea. Yep. O2 sats are low. Yep. And y'all are getting ahead of me here. What does their spouse tell you? Snoring. Exactly. Yeah. What else does their spouse say? They stop breathing. Scared. I wake them up. They go, what? What? I'm fine. Let me sleep. And you're not really sleeping that well. So if you have sleep symptoms like that, and the sleep study says you have 5 or more AHI in an hour, you got OSA. If you have 15 or more in an hour, you don't have to have sleep symptoms reported, you got OSA. Does that make sense? If you have 15 or more, you don't need sleep symptoms to be diagnosed with OSA. If you have 5 or more, you got to have sleep symptoms, and if you do, that's OSA. Good. Snoring and breathing causes it. Physical exam findings. What would be a physical exam findings for somebody with obstructive sleep apnea? Overweight? Yes. Sir? Heart attack? Okay.
A large neck.
Large neck, yes. Heart attack, large neck, yeah. Large neck is exactly right. There's a number that you need to remember with the neck. Females over 16 and males over 17 inch neck circumference. That's a risk for OSA. What's another, when you're looking in their mouth, you do a good AT&T exam, what was you looking at? Yeah, tonsils. and soft palate. You remember what that score is called? Y'all learned that? Somebody's name, they found it, French person. Potty score, yeah. The higher the number, the more closed that is. Somebody with a 3 or 4, and you can't really see that soft palate, that tongue's in the way. There's a lot of closed back there in that retropharyngeal area, and you say that's pretty likely, or makes sense that would be more prone to blockage back there, or close up. Somebody lay on their back, relax their jaw, and that close up together. Big neck, over 17 in males, over 16 in females. Does that make sense? Hypertension is another one. There's a pink box for it. This one has huge implications. This one, if you, the VA considers OSA, when you have OSA diagnosis, this is why at your exit interview, they say go get a sleep study. Because if you get diagnosed with OSA, the VA will give you 50% disability for that one diagnosis. You think, what? You just sleep. But when you deprive yourself of oxygen, your O2 sats drop every night for how many years, and you starve yourself and you're overweight, you got these other things going on, what do you think your body's going to respond with? A lot of chronic disease. And it makes your body not perform as well. And so the detriment that happens with OSA over time is badness. That's why we want to intervene and help them treat OSA and help them get better. There's your findings that we just talked about. Good job. When you treat somebody, this is what you do. Refer them to sleep medicine, they get the PSG, they say, yep, got OSA, then you refer them to or put in a referral for durable medical equipment, and they get a CPAP and a mask. And there are so many types of masks. And so tell them, be patient as you're working through which type of mask. You get a full face mask, you get just this one, you get nasal pillows, so there's all kinds of different ways to do that. But it's a big ordeal. You got a machine, you got tubes, and it goes to the bedside table. You got to have, it gives you a profile that you can only be deployed to places with hard facility and electricity. If you don't get sleep, you have those things that come along with OSA, daytime sleepiness and falling asleep behind the wheel. That's not good. That puts yourself and other people in danger. So consider the career implications with this as well. It limits their serviceability. Likely their return to duty, or with the code 2 or C code with their serviceability. So what else do? We encourage them to do those things. Sleep hygiene, we clean that up as much as we can. Lose weight, right? Don't have as much around here. Stop smoking. That's also, if you deprive yourself at night of oxygen, and then you smoke during the day and you deprive yourself of oxygen, that's a double whammy. As far as helping your body go downhill, we don't want to do that. We want to help coach them up in that way as well. Dental device, I got that up there. That's a more simple way and a less invasive way to help hold the jaw forward, kind of like when you're doing BLS, chin lift jaw thrust, open the airway. That's a little bit of what's going on with that dental device. So they wear the dental device and it keeps their jaw forward and keeps that retropharyngeal open. When they relax the jaw and it goes back, it's easier to close up. So a dental device may be all they need. That'd be great, wouldn't it? Instead of having a machine, mask, tubes, hard facility. If you got a dental device, you can go wherever you can take a dental device on deployment. Another one is a belt. You can give them a belt. There's a fancy ones that you pay a lot of money for. Or you can have just a pantyhose with a tennis ball in it. You tie it around their waist and put the tennis ball in the small of their back. So when they roll over on their back in the middle of the night, they want to stay off their back. And sometimes that's all you need to not have OSA, is to not be on your back. So it's simple ways, other treatment options that you can do. The most proven, the best is machine. CPAP, BiPAP, APAP. CPAP, it says continuous positive airway. Any guess on bi-level? What is the bi-level positive airway pressure? It's got different pressures preset that you breathe in and out that the machine adjust to as you breathe in. A PAP, automatic positive airway pressure, self-adjusts every breath to give you enough, ease off, give a little more, and so you don't get too much. So the APAP's pretty fancy. CPAP's the most common one that's prescribed, but you got a lot of options there, and sleep medicine will help work through that, please. There's a surgery, I put it down at the bottom, called UPPP, and I gotta look at the name because I can't remember. UPPP is the name, UPPP is the name of the surgery. Uvulopalato-pharyngeoplasty. It's a big name. And it's very invasive. They cut out a lot of the soft tissue in the back of your throat and try to open that up. Take your tonsils out, soften all that. And I've heard that it's very painful. And it's a painful recovery from. And that's kind of the last resort that we go to. Now the problem with that is, you look at the literature on how effective is that, as with anything, it can be out-eaten. So someone who has UPPP can eat a lot and wind up in the same boat, back to the OSA with that. So counsel the patient, hey, there's a lot of good stuff. We don't want to resort to a painful thing that may not last if we don't have other things in control before, like diet and portion control. So coach them up holistically and help them say, I want to eat that surgery. What else could it be? A lot of things. Could just be snoring. Right? The PSG, the sleep study will tell you that and help you out with those things. All right, circadian rhythm, sleep-wake cycle disorder is where the disorder comes from. Who does this affect? Who do you think this is? Say again, I think you're right. Shift workers, yep. Who's a shift worker? Healthcare professionals. Yep, you got the midnight third shift in the ER. Nurses, techs, providers, all of them. Anybody who works shift or flips their days and nights, that's where this can be. Or if you go across town, you travel a lot. Go across time zone, get in different times. Nights are days, days are nights. That's also very detrimental to health. You go back and forth from that a lot. You deprive yourself of sleep, and your body doesn't function very well. Remember earlier in this lecture, we look at how quickly it happens before you start looking like schizophrenia. Doesn't take long. Same thing with the oxygen that you need sleep. Sleep is good. Our bodies are designed for sleep. And you're saying, I know, but I'm in IPAP right now. Distress from the disturbance, so there's some diagnostic criteria. Sleep onset insomnia, so it's trouble getting to sleep, right? That's the sleep onset. And then hard time waking up because your body says, oh, finally, I get some sleep. And then you say, nope, gotta wake up, gotta go to work, gotta make your donuts. And then excessive sleepiness, and you can say that by shifting. There's a big box. What do we do for it? Like I mentioned before, sometimes you get a zolpidem or a handful of those when you go across time zone deployment to reset your body clock, reset your circadian rhythm when you get there, and that's a great way to use zolpidem or Ambien to reset that. Give them a quick, when you get there, stay awake, and then when it's nighttime there, take your zolpidem, sleep through the night. Maybe you need to do it 1 or 2 nights to get it reset, and then save the other 3 for your return trip back to the trip. So that's a good way to do that. That's a common way that you see where zolpidem is made. Before that, we love to use, and we talked about it yesterday, hydroxyzine, diphenhydramine, those antihistamines that have indications for sleep, but are less addictive. Street value is way less. Kudos to you if you get money off the street for Benadryl, but it works really well. And hydroxyzine comes in 25, and you can crank it up to 100 if you need to. You can take 2.5, and you tell them you find that where you're not groggy, but it helps you, and so you can do that very well. The main thing is we want to reestablish that circadian rhythm and waking up at the same time every day, sleep hygiene intact, and so we don't rely on the medicine, but this can help you reset that. Melatonin, some people ask about melatonin there. Melatonin, some people over the counter, it works great. If your patients, if you decide to go that route, good on you. You want to try that? It's fine. Melatonin, you got to look at the flight implications. Some of these are nipping or down meds. So if you get something that makes them sleepy, makes sense. You got to stay down or not take it within 8 hours of flight, etc. So check the regs where you are and who you're treating. But melatonin, sometimes somebody takes melatonin for a long time and they say, it used to work really great, but now it doesn't. Well, melatonin is naturally occurring in the body. So if you put supplemental melatonin in the body goes out. Somebody else is doing that. I don't have to do that. So the melatonin production from the body may go down, or the body readjusts and says, oh, there's a new normal, new standard, new average of what melatonin, the amount of melatonin is in my system, and so your body gets used to that, and you take it every night. So if that's the case, you can tell them, take a med holiday for a week or 3 off of melatonin, and then when you go back to melatonin, it'll work better again, because your body resets back to what you're natural in your body. And during that time, a week or 3, they're going to say, how am I going to sleep? Maybe you have an Atarax or a hydroxyzine that you offer them as that bridge between the melatonin supplementation. So that's a don't send your patients away sad. Have a plan. Have a backup. But hey, if you want the melatonin to work, take a break. Benzo, whoa, it's on the bottom. I barely even say it because that's not a good thing. It works. It works. That's all you got, and the other things don't work. But be careful of somebody telling you, yeah, I'm allergic to all these meds except benzos. Benzos are great. They work great. Careful of that patient. All right, RLS. Recreation leisure services. No. Restless leg syndrome. Restless leg syndrome. There's also, sometimes people come in with these symptoms of the arm or another limb. That's not in the diagnostic name. It's not restless arm syndrome, and so you treat the legs. When you call it restless leg syndrome with the leg, but if somebody comes in with the exact same with the arm, we can't call it restless leg syndrome, but we treat them the same. So search ICD-10, see if there's something that's similar to that, and see if it works. We're working back on. So what is restless leg syndrome? It's a desire to move the legs. You gotta move it. It's a compulsion, like, I gotta move my leg. Uncomfortable sensation whenever you don't. Some of those are there, creepy, crawling, tingling, burning, itching. And it affects your sleep, fragments your sleep. Sometimes moving the limb, look at the next slide. Sometimes moving the limb will relieve that. Sometimes for the night, sometimes temporarily. And so, gotta move it again. So it doesn't, for your spouse or a partner, and they're saying, quit kicking me. Man, you're moving all around. That's maybe this. It's worse in the evening, and it's worse it begins, worsens during rest. I don't know what I'm cutting in now. I'm just too excited. There we go. There's the 3s again. In our sleep diagnoses, you gotta have all 3 of those with the restless leg. Worsens during rest. When you lay down, it gets worse. Some people say, well, everything else is quiet, lights are out, that's the only thing you got to think about. It may happen the rest of the day. It's fair. Don't know. But it gets worse when you lay down for rest. Urge is relieved by movement, even if temporarily. And it's worse in the evening. We're only 3 times a week, 3 months. Clinically significant and not another condition or substance. There's the pink box. What do? This is really one of the only times you'll see this med, propinerol. We all have seen that med before? Okay, there you go, requip. Dopamine agonist, we treat RLS with propinerol. So if somebody's on propinerol, then you probably think they got RLS. Ask them, make sure, but that's probably what the diagnosis is if they're on requip. CBT might help some. We love it, so we give it to everybody. But that's chronic symptoms, the med comes first this time. We want to help them sleep better, and so some of this is under the umbrella of CBT or sleep hygiene. You don't want to nap during the day. If you're staying awake at night, it may not be the RLS, it may be because you overnapped and you're not sleepy enough at night. So helping with sleep hygiene in that way, and then lack of exercise. So if you exercise, that helps RLS as well. Sometimes you check the iron and see if that needs to be replaced as well. Aerobic exercise, we talked about that before, with autistic, with ADHD, it helps with a lot of things. Give somebody dopamine, it helps a lot. Play Candy Crush or take a lap around the house. At the bottom of the list, benzos. That's for refractory. If they can't sleep, they gotta sleep, and they're getting sleep deprivation because of this, maybe that's where you use the bridge for the benzo. So careful. Substance and medication induced. What do you gotta have to have substance medication induced something? You gotta have a substance and medication induced. Yeah. So in a test question, it's gonna be given to you or implied or pointed to, and then you gotta do a good history with your patient to say what meds are you on, what supplements are you taking, to know that and ferret that out. Here it is distilled from the pink box. Gotta have both. Started after the med or the substance they take, and the substance that they take is capable of disturbing the sleep. So if they take a substance, they take cocaine and say, this is messing up my sleep or making me sleep more, you think, wait a second. You're taking a stimulant and you're sleeping more? That doesn't make sense. But if you're taking Benadryl, 6 Benadryl, yeah, okay, let's ease up on the Benadryl. Doesn't happen exclusively during talk more about delirium and psycho. So what that's trying to say is there a different diagnosis that better explains that it's associated with delirium, and we'll talk more about delirium in a subsequent lecture. So that's another way of saying, is there a better diagnosis that explains what's going on? Clinically significant, is it in the main question, and like seeing you in clinic? Yeah, clinically significant. There's the big box. Here's some sleep questionnaires. You give somebody, again, don't throw them the scores. A lot of times the Epworth Sleepiness Scale, if they score a 12 or higher on that, then that's something that you send them to sleep medicine, and they probably will be a sleep study for them. You report that Epworth Sleep Scale ESS score in their referral to sleep medicine, and then they'll take that seriously. Please rule out OSA Epworth Sleep Scale score of 17, and then they'll take it. Don't tell the specialist what to do, but tell them why you sent them to them, the question you're asking them to answer for you. Please, pretty please. You're smarter than me. Please teach me. Stop bangs another one. All right, questions about sleep while I switch our slideshows here. Everybody is asleep. I'm going to skip our practice questions for now, because I think if we make it through these lectures, we may get to lighten up some of the double D's. If that's okay with y'all. We'll do practice questions for sure at some point. Next we'll talk about somatic disorders. These patients, somatic disorder patients, can be very frustrating. These are the ones who you need to set healthy boundaries. So all up until this time, for the most part, I've been saying, be vulnerable with your patients, relate to your patients, make yourself available to patients, talk to them. There's a line there, and you gotta respect that, professional line, but also you gotta be wary and use that emotional intelligence to say which patients to open up to, which patients to be vulnerable with. Somatic patients, you gotta have strict boundaries with. Don't give them your phone number. Don't tell them the code to the back door. Don't give them, a way to get into your clinic or to have extra appointments. You want to have healthy boundaries, and that's good for the patient too, not just protecting your sanity or your family, but to protect them too. If they come back early and you say, hey, did you do what we said the plan? No, I thought I'd come back and tell you because I had some more ideas. Whoa, we had a plan. You got to do the plan, and then we come back and talk about the plan. That's hurting the trust, and I can't trust you as much if we agree upon this plan. Let's do the plan. So you gotta have some frank conversation with this patient and keep those out. You wanna be professional, courteous, on their side. At the same time, you wanna draw those lines. And when you have boundary lines in pleasant places, that's very comforting a lot of times. Sometimes they don't want to, they push at those, and you got teenagers, push those boundaries to find out where they are. But it's very reassuring to know there are boundaries. Do your due diligence with everybody. Even the knuckleheads get sick. So you see this person the 6th time this week in the ER. Oh gosh, there's Mr. Jones, he's back. Do your due diligence, good history, good physical, and treat what's there. Don't miss something just because you're frustrated with something. Here's what it is in reference material. Here's the syllabus, what we're going to talk about. So a few definition of terms. Somatization is physical symptoms that mimic a disease that's not there. And psychological distress that's felt in physical form. So we'll talk about differences there. Physical symptoms not congruent with a disease. So kind of like we talked about affect and mood. If they're congruent, that's a good thing. If they're not congruent, then you ask more questions. Same here. If the symptoms don't match a known disease, then you say, well, that doesn't match, that doesn't line up. Then this comes on in differential as well as a consideration. So what is a somatic symptom? Some of these you can see, and some you can't. So pain, I know, I get it, subjective, but in somatic symptom disorder, pain is considered a somatic symptom, and it's the most common one. So that's, we need to know that. Although pain, we can't put it in a jar, put it on a shelf, label it, and sell it. Pain counts as a somatic symptom. Tremors, you can see, right? Paralysis may be subjective as well, but that's also a somatic symptom. Shortness of breath, these are symptoms, somatic symptoms. Many times when these symptoms are present, there's an underlying psychological reason for them, and so you want to look at the person behind the symptom. You got a question? Yes?
Is it associated with like a person that's hypochondriac?
Oh, we're going to talk about it. Good question. That's a great, good Levi, good teaser there. Yeah, we'll actually say that in just a little bit. Thank you for that question. She asked, is it associated with hypochondriacs? Yes, it is. And we'll talk about it. Good job. Those are some examples. That's not an exhaustive list, but somatic symptoms. There are some examples. So when we're looking at this lecture and the different diagnoses in here, we want to look at differentiators and how we can tell them apart. These are two big things we want to ask ourselves. Are there symptoms present? Or are there no symptoms present? That's the first one. And then is there secondary gain or not? No secondary gain. We'll talk about what secondary gain means in a little bit. But those questions, every time, if you're reading a question, you think, oh man, this is from somatic disorders lecture, I got to ask those two questions. Are there symptoms, and is there secondary gain? That narrows it down quite a bit for us, and we'll see why here in a minute. So, poster child diagnosis in this broad category, somatic symptom disorder. This one has symptoms. Symptoms are present, somatic symptom disorder. Typically multiple symptoms, but not always. But they have to have one. Sometimes hard to prove, back pain, headache, but it's a symptom. It counts, remember pain counts as a somatic symptom. And it's the most common. This one, they worry a lot about it, they have a symptom, they worry a lot about it, they're seeing you, they're asking about it quite a bit, and they might doctor shop around and somebody says, hey, get out of here, there's nothing wrong with you. They're going to go to somebody else and ask them the same question. They're going to keep at it. You don't give up. If you are a good provider and you provide a good logical explanation, you do your due diligence, good history, physical, labs, rad, special tests if you need them, and you rule out what's going on, and it's very clear, you convince them of that. Many times this is where the frustration comes in. You'll say, there's no reason for your back to hurt. We've done all the tests, it's all good, I think you're fine. Go forth and prosper. And they'll say, Yeah, but my shoulder hurts. All right, now it's a shoulder. Right? And so you're asking me, does it have to be the same symptom for the 6 months? No, it doesn't. It can be multiple symptoms. It just has to be continuous over that time. There you go. Doesn't have to be the same symptom for the entire 6 months, but it's continuous. Okay, you convinced me my back, nothing wrong with my back, but my shoulder, my ankle. All right, let's start to work on that. Let's take care of it. And you make a plan, and you get that agreement, you stick with the plan. Out of proportion to the seriousness of the symptoms, my shoulder hurts, therefore I got cancer, I'm probably got a month to live. Right? Doesn't match up, right? High anxiety about my shoulder pain. Well, you're 42, sir, and many people that are 42 have low-grade shoulder pain. We'll work with you. We'll hopefully improve that, but it's not uncommon. So don't worry too much about it. We'll do due diligence and take a look at it, make sure nothing big's going on, that you need any intervention or surgery or chop your arm off. We don't need to do that. We'll take care of it. But they spend a lot of time. They're the ones that bring in the printed out stack of WebMD about all the things that can happen because his shoulder hurts, and they want to talk to you about all of it. So when you see them on your schedule, you go, oh, well, that's going to be more than 20 minutes. So that's where the boundaries need to be drawn and say, all right, you can't talk about 12 things today, or your top 2. And my tech will schedule follow-up appointments, and we'll work our way down this list. What are the top 2 on your list you're most concerned about? And you go from there. Here's the pink box. Remember, somatic symptom disorder has symptoms. There's what else it could be. What's the first rule of psych? Rule out organic etiology. So knuckleheads, there could be something going on. So don't dismiss them and then find out 6 months later, oh man, this is metastasized. And if I'd have done the right thing to start with, we'd have caught this and taken care of it. Just don't be that provider. Do the right thing even with the knuckleheads. So first line treatment for true somatic symptom, once you rule out organic etiology, you've done your due diligence, is social and peer support, and not just for the patient, but for you. To make sure that you're staying composed. Maybe you need to go close the door with your colleague and vent about this person, and hey, please help, give me ideas to help take care of the patient, because they are frustrated, need to know it. You gotta have support as well. Don't do this alone. It'll be very, very frustrating. Healthy boundaries. You want to, but seriously, first off, social and peer pressure support. Pressure is a good thing, good person. CBT. Yep. Group therapy. And then get psych on board. Don't treat this patient alone. You get a professional counselor on board and talk through with them. And hopefully there's some self-realization that happens there as well. So when they come back to you and say, my counselor and I have talked about this and I understand, I can kind of see myself and say, I get worked up a little much about these things, but my shoulder still hurts. Okay, we'll go through your shoulder. That's progress. That's good. You want to get mental health on board, but remember to set healthy boundaries and do your job. Don't miss actual pathology. The temptation here is to throw meds at this patient and tell them to go away. Or when they call in asking for that appointment, I know you said not to come back to 2 weeks, but I really got to see you, is to prescribe meds and push them away. You don't want to start them on meds when they don't need meds. Lowest effective dose, if that means no dose, 0, nothing, that's what you want to do. So if there's no indication, don't give them meds. That's a temptation though, because they feel like you did something for them. You send them away, now you've created more problems. Especially if it's something that they will become dependent on, even if it's not an addictive medicine. It's even worse. If you give this person a benzo, don't do that. Think thrice before you give this person, for sure. If we need to get to a med in refractory cases way down the road, we go Muhammad Ali. We go SSRI or SNRI and antidepressant. And that UTD, that's up to date, that's where that source comes from. Another source to tell you, yep, that's what we want to get. And just to tell you, that's a good source in the clinic to double check what you know, see if it's still the most current thing on the list, because some of the things we'll teach you, they'll refine or get better after you graduate from IPAP and you go on to be a great PA, like I know you will be. Things change, medicine changes, it advances, so make sure you're doing the right thing after this. Don't give meds, just get rid of them. All right, next one. Here's your hypochondria. It's now called illness anxiety disorder. Used to be called hypochondriasis, or that's where you can see the hypochondria. This one does not have symptoms. So that first question we ask ourselves, there is no symptoms with it. Illness anxiety disorder. Hypochondriac has no symptoms. But there are a lot of anxiety about one day getting an illness, a serious illness. These are sometimes termed the worried well. They're healthy, but they're worried about getting sick. So they'll come in and see, well, what's gonna, this is a tough one. It's tough to get, but tough to get rid of. They're worried about a serious illness. That's part of the diagnostic criteria. There are no symptoms, sometimes very minimal, and no symptoms. Therefore, they think something's a symptom, but it's not there. So no symptoms is the bottom line there. But they got a lot of anxiety about getting something. So we say the word anxiety, and then other diagnoses come on the table, right? So we want to make sure other diagnoses aren't present, or they're on a better explanation for what's going on. There's a time component here, 6 months. You got to be worried about having a serious illness for 6 months with no symptoms. And it doesn't have to be the same one, just like the somatic symptom. There's the big box. What else could it be? A lot of things. Even the knuckleheads get sick, so do your due diligence. 6th time this week in the ER, do your due diligence. Don't miss something just because you're frustrated. What do we do for them? CBT. Help them get through. What happens when you have that feeling come up? How do you approach that? So give them tools, psychological, mental tools to be able to work through what happens, and they can reason with themselves and give them tools to do that. Like I was talking about before, limit the number of symptoms at each appointment, set those healthy boundaries, have a specific plan. Better if you write it down and give it to them. You put a copy of that in the note, so you can pull up the note when they come back in. Say, remember that plan I gave you? No, I lost it. All right, well, here it is. I got it in the note. We said 2 weeks. It's 1 week. So we don't know yet. We got to wait 2 weeks to see if this is going to work or not. So keep at it. I'll see you in another week. Look forward to it. Don't miss actual pathology. I keep saying that.
How do you approach these patients about, like you're seeing them multiple times, they're coming in, you know that this is related to psychological anxiety. How do you approach the patient to kind of like tell them, hey, like you don't have anything, I think this is a psychological thing. You should go and get like psych help or behavioral therapy. How do you go about that conversation with the patient?
That's a great question. How do you delineate or say psychological versus medical or physical and say those two things? There's sometimes when I'll separate those to the patient and say, I'm going to take care of your body and then the mind. Yes, I'll take care of that too, but we got another team that can help you with that, right? So I'm going to answer the questions, the objective questions about your body. So we'll take the rad special tests and we'll see if anything's going on there. And then I want you, part of this plan is the mental piece. So we got to see mental health and make sure we're taking care of you there too, even if it's just for a checkup. I'm not calling you crazy. I want to give you tools if we find something. If we don't find, either way, how you process this, how you deal with this, how you live with this. I've diagnosed them, I haven't told them anything's wrong with them, but this, what you're telling me, I don't see anything wrong. We need to get mental health, not because you're crazy, but how to process this. So they'll help you do that. Does that help? Is that okay? It's not a clean, it's different for every patient. You get practice, so watch your preceptors and ask them that question. How would you do this? What would you, if a patient said this, what would you say back to them? Get that, because there's a lot of experience and wisdom there in the precept. All right, 10 minutes. Let's see you in 10 minutes. Conversion disorder. We'll call it conversion disorder. You also see it as functional neurological symptom disorder. But we'll call it conversion disorder. And I feel like it helps us remember what it is and where it comes from. This patient has symptoms. The symptoms are present, but they don't match with a neuromedical condition. So this is conversion of a psychic conflict into those physical neurological symptoms. So you got to know that there was something happening. So 2 months ago, I got in a fight with my mother-in-law, and since then, I haven't been able to. Then the symptom presents. So there's something that happened. You can trace it back to something that happened, a life event or a psychological conflict, something that happened there. And then sensorimotor. So sensorimotor is something they feel or move. So those are where the symptoms come from, feel or move. And if you see also anxiety, depression, and panic disorder, a lot of times those can go together. And it makes it easier to trace it back to. But this is where it's not clean, where the patient knows to come in and only has one diagnosis every time, every patient that you see. They may stack them. But to know this one, conversion disorder has symptoms, and it's linked to, traced back to a psychic conflict. With neuromuscular, so sensorimotor, feel or move something. Here are some of the common symptoms that present sensorimotor symptoms. What's aphonia? What does that mean? Loss of ability to speak, phonation. Did you hear that? A without phonation. How about dysphonia? Is dis without, or is it difficulty with? Difficulty with speaking, right? So aphonia without speaking, dysphonia, difficulty speaking. Good old medical terminology coming back at us, right? Anarthria, another way to say loss of ability to speak. Dysarthria, difficulty speaking. Dysphagia. Swallowing, eating, drinking, difficulty swallowing, dysphagia. You'll hear that a lot in your practice, dysphagia. Get a bearing, swallow stuff. You might know that for this class. Dysphagia, swallowing, arthria, speech, phonia, sound or voice. These are some of those sensorimotor. Feel or movement, those are the symptoms that present with conversion disorder. They have symptoms. Can stem from, yep. It can be traced back to, and it has. It doesn't match. You get send them to ophthalmology, do all the imaging and everything looks good. They respond to light. It doesn't make sense. It doesn't match up with what the patient says, I can't see. And it's real to the patient. You can't move, can't see. So that's the puzzling part that comes with this. You trace it back to ever since my deployment, or ever since I got blown up on that roadside ID. That's when this started happening. So you work them up, you do the right thing, you don't find anything, but still the symptom is there. That's when you consider disorder. Sensorimotor, feel or movement linked back to a psychiatric event or crisis or conflict. Ricky Bobby, famously, after his car wreck, said he can't walk. No reason. They did the full workup, but he still said he can't walk. Stabbed himself in the leg and proved to everybody, and quickly found out I'm okay. That's an example. It's not that clean and a quicker recovery a lot of times for people, but that is part of, you want to do it a little less barbaric than stabbing in the leg. You don't want to stab in the leg. But you have at least one, there could be more than one, at least one symptom. So symptoms are present, again, conversion disorder, symptoms present. Voluntary motor sense, so feeling and moving, voluntarily feeling and moving. That's what the symptom for this disorder is. Doesn't match, not enough to diagnose it. Don't use this as a garbage or bailout. If you can't find a reason behind something, do your due diligence. Rule out organic ideology, even for the knuckleheads. Don't miss something. There's a big box for it. What else could it be? So many things. That's why you want to stick to your rubric. Go be trustee, take good history, do good physical, order what you need, lab run special tests. And then you say, well, what if they're faking for it? This is malingering, tells you, and this from that differential diagnosis section. If you haven't checked that out, here's an example from there, again, to help you differentiate from other things. So malingering is faking something to get secondary gain. What if you're faking something and then you aren't pursuing secondary gain? Factitious disorder, we're just coming right up. But malingering is different in this one. Conversion, they don't want it. It's there, they don't want it. You can trace it back to psychological prohibition. Malingering, they pretend, so they get something. Factitious disorder, they pretend with no obvious external gain. We'll talk about those in a second. What do you do for conversion disorder? Well, you don't laugh at them. You don't tell them you're full of it, kick them out the door. You take them seriously, you be a professional, you be a provider, and you look out for them and do your due diligence. You build trust, because if you don't build trust, they're just going to go to somebody else. I don't want this. I've got this. You're laughing at me. I'm going away. I'm going to somebody else to take me seriously. So you get them into physical therapy, CBT, and help them move like Ricky Bobby. All right, let's try. Let's hook up some EMG, right? Some stim, to activate those muscles. You feel that? And slowly get them working. And so get hands-on with physical therapy on your team. A lot of times that's the road back to recovery. So we get them help treat the symptoms that are there, treat what you see. Don't miss something. Even if it is conversion disorder, the symptom's real, they don't want it. And help them with it. And always assess SIHA. You can think about it. Somebody has a traumatic event, psychiatric conflict, they got a symptom they don't want, and they can't rid of it, nobody takes them seriously. How much do you think suicide and homicide comes onto the radar? It does. So we want to check in with, don't add to that frustration. Don't ratchet that up by how you treat them. But assess for it, keep that on your radar too, differential SIHA. Come alongside. Takes time. Takes time. Again, this is the same slide, same treatment as far as meds go. Rarely helps with a med. If you don't have a real reason for it, no medical definition or medical support for their symptoms, don't throw meds at it. Do your due diligence and be patient. Come alongside the patient. Same treatment as somatic symptoms disorder, same treatment as illness, anxiety disorder. Factitious disorder. Pretenditis. Just kidding, that's not an official term, but pretenditis. This is one that has no symptoms or falsified symptoms. So they're not real symptoms, they just falsify. They present themselves as ill without signs of obvious external reward. So what is external reward? There's external reward, that means there's internal reward. So external reward are things like money, discounts, coupons, a raise, stickers, trophies, awards, time off work. Those are external rewards. Internal rewards, which is not what we're talking about here, is sense of accomplishment, pleasure, sense of purpose, meaning, intellectual stimulation, being needed, wanted, cared for. That's internal reward. So external reward, I'm faking this injury without that external reward. So it may be something that they want to feel needed or wanted. Remember who we talked about before? That fits this, imposed on another. Yep, also known as Munchausen by proxy. Gypsy Blanchard, Mom Didi. So factitious disorder without obvious external reward. So mom didn't do this to get paid. She did this presumably to feel needed and wanted by her daughter, to be the caregiver for her daughter. That's internal reward. So external reward is what is absent in factitious disorder. And there's another one of the difference between factitious disorder and malingering. Malingering has obvious external reward. So they're doing this to get paid. Malingering, doing this to get paid. Factitious disorder, not doing it to get paid. More than likely internal. There's a differentiator between the two. Both of those, no symptoms. Somebody's making this up. Avoid punching them in the face. Don't do that. Avoid kicking them out. Judgment, anger. Talk to them. Be honest with them. Back to your question about what do we do with somebody who is faking something, or the psychological is creeping in, or is the only thing on the table. Be honest with them and say, here, I think this is what's going on. I think this is the best thing for you. They won't like that many times. Or their supervisor brings them in and says, this person's been lying to you. All right, well, it's wasting my time. So how do you handle that as a professional, as a provider? Even knuckleheads get sick, so after that they come in, do your due diligence, your history and physical, make sure you don't miss what's actually there. Same treatment. Maybe SSRI if it's refractory a long time down the road, and don't give them meds just to kick them out, just to get rid of them. Can be presented as very believable. Remember the slide before about the kid getting seen 300 and something times and having major surgeries? Can be presented as very believable. So that's where you have to be astute as a clinician and do your due diligence and not just be convinced and be sold a bill of goods. You take that, you listen to the patient, but do your due diligence to rule in or out what you need to. We can make this worse if we're rude to this patient, if we have a poor attitude, if we get angry at this patient. We can exacerbate this and make it harder on ourselves and other people as well. So that's why you want to remain professional, especially with this person. This is the one who will make your life hard through the comment card and ICE complaints and the patient advocate, and now your time is spent answering these inquiries instead of taking care of patients. So be a good provider, be honest with them, but don't be unprofessional. This is one where you think, oh man, I wish I could go back to that one day and not say that response to that patient. Be professional. Here's some tips, practice-wise. You can take this with you on how to handle, kind of to your point, about what do we do with this person. Here are some things, some ideas that you can look at and consider whenever you get somebody in and you say, man, I don't need to be seeing this patient. There's nothing going on. Or I've seen this patient for the same thing. I don't know. Take a step back, swallow your pride and say, am I missing anything? Does somebody else need to put eyes on this? What am I missing? Do your due diligence. All right, questions about that while we're switching slides here? Yes?
For conversion disorder, do the symptoms have to be present like constantly, or can it be something that like shows up and then it gets better and it comes back?
Yep, pretty constant. So it's got to be there for pretty constant. And you think it doesn't, maybe it goes away and comes back, but it's got to be pretty consistent throughout that situation. Good question. We'll save our practice questions for the end if we've got time, but we're going to press on psych. Any other questions so far? Somatic disorders. We'll go through some practice questions here at the end and see if we can do that. Schizophrenia, psychotic disorders. This is where you thought psych was going to be from day one, didn't it? We'll get into the meat, into the fun stuff. Here's where the reference material refers to this. Here's our syllabus, what we're going to talk about today. Here's some definitions, which we'll put a little more meat on terms around this as we go. We'll reference these as we go, so I won't talk too much, but schizophreniform, the first one, we're going to refer to that as schizophrenia early, because it hasn't formed fully yet. So So we'll look at time component. This was 1 to 6 months. Schizophrenia is beyond 6 months. So if it looks like schizophrenia, but the time component's not yet, kind of like trauma, same principle there. It's schizophreniform because it's schizophrenia early, hadn't formed yet. Schizoaffective, we're going to call schizophrenia plus. It's got to be schizophrenia plus a major mood episode. And as we notice, we'll talk about it. Substance induced, we already know what that means, right? Due to another medical condition, we already know we're looking at other things. And then unspecified, there's our garbage can. We'll sum up all the schizo diagnoses there at the end. Here's a cliff note chart we'll show at the end as well, come back to, but here's kind of a breakdown, the bare bones of what is schizophrenia. 2 or more symptoms for 6 months. Schizophreniform is not there yet. Early, you got 2 symptoms or more for 1 to 6 months time frame. Schizoaffective is schizophrenia plus. You'll know there's no time requirement there for schizoaffective. There are also some other nuanced diagnostic criteria with schizoaffective, which is too much in the weeds for this course. So in this course, when you look at it later, you say, wait, there's a little more here that we need for schizoaffective. I get it. We're not going there. We're just going to call schizophrenia plus a major mood episode without a time requirement. And then brief psychotic, that's what happens if it's 1 or more symptom and it's not yet the schizophreniform. It's that 1 day to 1 month. So that's the early one. Brief psychotic, schizophreniform, and schizophrenia. That's the progression in the time component. Delusional disorder is just that. It's not hallucinational disorder, it's delusional disorder. So it's just that 1 symptom for 1 month. We'll talk about each of them. We know these, we've talked about these before, delusion, hallucinations. We've got our handy picture slide on the next one, we'll come up to the next. But then there's a couple of them that we'll need to get some definitions for. Disorganized thinking, there are different versions of that. Derailment, somebody who switches, like a derailed train from one topic to another. That's what that means. Tangentially, you ask a question, and the answer to the question is a little bit off. All right, so if your compass, if you aren't account for declination, then you're going to be off, kind of the same way. If your heading is off, you wind up in the wrong place. That's the same here. Tangentiality, you ask a question, the answer is not really on topic, it's a little bit off. And incoherence, this is when you can't even understand what they're saying. There's some video examples there at the end. If you watch those early on, you'll see some examples of this in real patients. Catatonic behavior, famously, this is one where people would just sit there and there's no response. If you've seen Awakenings, Robin Williams, Robert De Niro, this is a great movie. But catatonic state is where somebody sits there, drools, and doesn't move, rarely blinks, and is unresponsive to the world around. That's catatonia at its classic definition. Sometimes there is repetitive movement, excessive motor activity without obvious cause. So maybe there's a tremor, or they're doing something repetitively, but don't respond to the environment around them. That's also catatonia as well. There's our classic, we know what this is. There's a reminder of it, hallucination leading delusions. So we're looking at negative and positive symptoms. When we diagnose schizophrenia, we'll need to know negative and positive symptoms. So negative takes away something. So it's the absence of, kind of think of it that way. Inability to show emotions, apathy, difficulty taking, talking, and withdrawing. Withdrawn from social situation, so it's a negative, it's taken away, something's absent. And then positive is adding something additional. The delusion is not usually there. Hallucination is not usually there. Repetitive movements, that's added, that's a positive symptom. Not as in a good thing, but it is in its added. You can think about negative symptoms, lack of pleasure, trouble with speech, flattening, withdrawal, struggling with the basics of life. What else does that might sound like? Depression, yeah, Siggy Capps, doesn't it? So we got to say, is there a better definition before we slap schizophrenia on them? Is there a better definition? Is the power of suggestion go to your rubric, right? Due diligence, history and physical, so you don't misdiagnose somebody unnecessarily. Schizophrenia, we look at that picture just for a minute before you see it. Yep, 2 symptoms or more for at least 6 months. And one of those symptoms has to be a positive symptom. So the first 3 are positive symptoms, positive psychotic symptoms. You have to have one of those 3. And then disorganized behavior catatonia. Catatonia is the absence of interaction with the world around it, right? And negative symptom, any of those other ones are referred to or alluded to. Time component, persisting 6 months and 1 month of the positive symptom. So you don't have to have the delusions, hallucinations, or the disorganized speech for all 6 months. You can have that for 1 month, but then the other symptoms persist for that 6 months before you can call it. So there's our 6 months for schizophrenia, at least. If it's less than that, then we're thinking about brief psychotic disorder in that 1 day to 1 month, or schizophrenic form, 1 month to 6 months. And if it's over 6 months, then we think about schizophrenia. Now at the bottom there, if history of autism disorder, you can't count disorganized speech as a positive symptom. Why not? Why do we think that? They may not what?
They might have that capacity.
They may not have that capacity because of autism. Yeah. If it's better explained by another diagnosis, then we don't lump that in. So if they're autistic, history of autism, you can't count disorganized speech as a positive symptom. So if you're reading a medical question and you see somebody with a history of autism, then you're thinking, and then later on you're looking and asking you about schizophrenia, and you're thinking, oh, this sounds like schizophrenia. You can't use disorganized speech as the mandatory positive symptom. That makes sense. Now, persisting includes, y'all haven't had neuro yet, but if you think about headaches and you have prodrome and postdrome, does that make sense? You kind of feel it coming on, and there's a ramp-up period to the disorder, classically migraines, and you'll get to that. There's a prodrome, or somebody will say, you know what, I see this in my vision, or I just feel kind of weird, and I know a headache's coming later. That's predrome. Prodrome, that is similar with schizophrenia. People can say, oh, this is ramping up, and it's not there yet, but I can tell it's getting there with my mood and these symptoms. Whenever you count 6 months, you count the predromal and postdromal periods. So you count that ramp up and down to make that time requirement. Not just at the height though, when they get there, you count the ramp up and down for that time component. There's the pink box. You need 2 symptoms. If you only have 1 symptom, then we think of another diagnosis. You gotta have 2 symptoms to be schizophrenic. Remember the history of autism. Gotta ask for that, gotta find that. If you're thinking about diagnosing schizophrenia, you gotta ask about autism. Suicide risk, as you can think, people go in and out of these positive symptoms, and when they're in the symptoms, and delusion and hallucination, that is real to them. And then they get out of that, and they realize, look back on it and say, well, that wasn't real. That's a scary place for them to be. And so you can imagine that suicide will creep on and say, I don't want to go back there. Kind of in the same way bipolar, I hurt people when I'm there, when I'm manic. Same way with schizophrenia, I hurt people when I'm psychotic, when I'm in psychosis. And I don't want to go there. I want to cause other people pain. So suicide creeps on the table. We got to keep a close eye on these people. A lot of people attempt it and die by it. And that risk remains for a long time. We can't predict the regularity with which psychosis happens in somebody. And so you always got to have it on the table and on our radar with and for them. What else could it be? A lot of things. I mentioned bipolar. That's one of the things we want to rule out. Make sure we're not on the dig fast train. PTSD train. Dig fast acronym. ASD, what's ASD? Autism spectrum disorder, yeah. What's OCD? Obsessive compulsive. What's MDD? Like a super doctor. Major depressive disorder. Good. And what's DO? Doctor of osteopath. Disorder. I didn't mean to equate those two things. I love DOs. DOs are great. They do well on feet. I love on feet. All right, well, how do we treat them? The first thing our concern is safety. So if somebody is psychotic or is in psychosis and they're listening to the voices, or the voices are telling them hurt somebody, hurt themselves, that's a scary place. So you got to protect them from themselves or the people. So you think about straitjackets, padded rooms. That's where this comes from, and now you can maybe see, oh, that kind of makes sense, and it's actually not torturing the individual. They're trying to protect the individual from themselves so they don't hurt themselves. So you get at themselves, and that may be how they would hurt themselves. Again, those videos at the end, if you want to watch some of those, one guy is videoing himself, and I apologize for some of the language in there, but he's talking to you as he's in psychosis and giving you visions, and he's saying, okay, right now I'm seeing, and it's fascinating to hear from his perspective. He has self-awareness. You can tell he's on meds and in counseling to say he has self-awareness enough to say he's the guy that's smoking. His camera's right here. Okay. Fascinating to watch and look at. When it's the first time somebody presents with this, why wouldn't we do a full workup with brain imaging? Rule out organic ideology. What else could be going on? I know we haven't studied a lot of this yet, but what else could be going on? Tumor, mass, pushing on stuff, making us think something. What else? Hemorrhage, yeah. We got hit in the head. Forgot they got hit in the head. Another bleed internal. You want to rule out organic ideology. If it's the second time they come in, same symptoms, same everything, you may not need brain imaging. But first time it's mandatory. First time presentation with psychosis, brain imaging. It's a big deal. That's part of ruling out organic ideology. Full medical eval. So when somebody has psychosis and we rule out organic ideology, and we're convinced it's psychosis, schizophrenia, we want to treat them with. If they're psychotic, we want to treat them with a antipsychotic. Yep. And if we want to do the cleaner, better version, do we do the first or second gen? Second gen antipsychotic. Yep. So this patient is psychotic. We want to give them an antipsychotic, and second gen is a cleaner, better version. So, antidepressants sometimes. Anytime you give somebody antidepressant, what do we want to rule out? What condition? Bipolar, yeah. What is bipolar? What's the underlying thing that is a major component of bipolar? Mania. Yeah. We don't want to do what with an antidepressant? Switch them. Yeah. We don't want to push them in too good of a mood, or they go to Vegas and gamble away all the family's money. Yeah. Safety is the first goal. Brain imaging on the first presentation, and a second gen antipsychotic. That's what we want to do. First one is there. First gen is okay. They say, yep, this runs in the family. Mom, dad, brother, sister has this, and they're on this first gen antipsychotic, and it works well with them. That may be somebody you consider, but what are we going to keep a close eye on to watch for? Weight gain, okay. What's a little more serious? That's more common. I appreciate that. What's more serious but rare? Say again? EPS, exactly. Extrapyramidal symptoms. Good. What's an example of EPS? Dystonia, yeah. Toad. All right. What about if they come in like this? Dystonia, akathisia. What's that? Needs being constant motion. Which one of those is the most common? Akathisia. Akathisia. Good. Good. Now, look, sorry, I'll go back. When you prescribe an antipsychotic for psychosis, walk alone. It's going to be a long route. Because you won't see max treatment for about 6 months, and they're probably going to be on this at least 2 to 3 years, because we can't predict when the next episode of psychosis is, and likely they'll be on this for the majority of their lifetime. So schizophrenia is a big deal, and it is life-changing when this diagnosis. We don't want to miss it, but we don't want to jump and reach for that diagnosis. There's our med slide for the EPS. You guys nailed it. They're all over it. That's what could happen. And there's black box warning with those two. Be careful who you get to. All right, brief psychotic disorder. This is the one day to 1 month. And we only need one symptom for this one positive symptom. That's all we need. 1 day to 1 month. A lot of ones for brief psychotic disorder. Ones. Positive symptoms are what? What's the example of positive symptom? Added. Yep. What's the examples of added things? Seeing stuff, which is called a what? Hallucination or delusional, fixed false belief, right? And then what's another positive symptom? Disorganized speech. Now, in which patients does this organized speech not count? Autistic, yep, because that could be just their autism. A little bit of tism, snippets, right? Rhythm with the tism, so a friend of mine said. He has autism, so it's funny coming from him. It's not in the sense of don't tell that to your patient, especially have a real good relationship with him. Yeah. Now, when we say 1 month, brief psychotic disorder, and we know from schizophrenia, the same is true here. The pre-dromal and post-dromal count in that. This has to be gone in 1 month. This has to be gone in 1 month. So that's pre-dromal and post-dromal from this one positive symptom. If it's not gone in 1 month, what do we start considering then? Psychosis, what diagnosis is that? After 1 month, 1 to 6 months is which one? Schizophrenia, not yet. Schizophrenia form. Schizophrenia form. Yep, hadn't formed yet. 1 to 6 months after this, and they get another symptom, maybe a negative symptom. And that's schizophrenia form. After 6 months, 2 symptoms persisting. Schizophrenia, full blown. Schizophrenia. Good job. 6 months. Good job. More than half of people with brief psychotic disorder have a relapse. And so we don't just say, oh, good, you're done with that. It's gone after inside of a month. Have a good life. There's a ping box. So what do? We treat it just like we do schizophrenia. And you say, wait, it's brief. It only got one positive symptom. It's gone within 30 days. But because it usually comes back, and if it persists, then we call it something different. It's the same way you treat the patient, not the diagnosis. We're going to treat somebody as if this is coming back. That's the way you treat brief psychotic disorder. Because usually it'll be another one, and it may be longer, and then they get a full-blown different diagnosis. So same way we treat schizophrenia. What else could it be? A lot of these. I'm not going to mix those options on a test. Depressive disorder with psychotic features, that's kind of unfair to you guys at this point. What do we call schizophrenia plus major mood episode? What is that called? What's the diagnosis? Schizoaffective disorder, that's right. Schizophrenia plus major mood episode, that's schizoaffective, just below it. This is when you get out the DSM and you look at those pink boxes and you say, all right, which one do I call this? And you phone a friend and say, hey, that's what I'm thinking about mental health. What do you think? You've talked to them. Or I want you to talk to them. Yeah. There's where we say the brief psychotic is gone back to baseline inside of 1 month. And that ramp up and down are a part of that. There it is. More than 50% have that relapse. When it's favorable, if we get on and treat them, that they can function in life. So we want them to do that. Delusional disorder. Don't you wish your girlfriend was hot? Sorry if that's going to be stuck in your head for the rest of your life. Delusional disorder, not hallucinational disorder. Delusional disorder. And again, one symptom, which is delusions. 1 month, and that's what delusional disorder. There's a lot of subtypes we're talking about in a minute. We need to be able to distinguish which is what whenever we get there, but I'll give you some examples when we get there in a couple slides. We want to make sure that we rule out other things, organic ideology and other diagnoses, but delusional disorder for 1 month is delusional disorder. Delusions for 1 month, delusional disorder. There's a pink box distilled out if they've never had schizophrenia diagnosed. So if they've gotten 2 symptoms for over 6 months, we don't downgrade them to delusional disorder. Same thing as if they've ever been manic, a patient has ever been manic, we don't downgrade them. Bipolar 1 never gets downgraded to bipolar 2, right? And it's got to be different. If any bipolar symptoms got to be different and mild compared to their delusions that they're reporting here. Delusions has got to be loud and clear. That's the thing that's on top of the radar when we're talking delusional disorder. There's the pink box, and here are the different types. We talk about erotomatic delusional disorder. You put that prefix on the, or that delusional disorder, erotomatic type. That's when another person is in love with them. Grandiose, I'm a great talent, but it's unrecognized. Insight, discovery. I have great insight, I have great discoveries, but it's unrecognized. Jealous is when the patient is jealous of another being unfaithful. The classic is a guy, and there's some examples in the videos, a guy being jealous of his wife cheating on him. He's not trustful of his wife in that marriage relationship, which is sad when you watch. Now the flip side of, and you look at these and say, it's this person again, they got delusional disorder. There could be, there could be truth to that. So that's why we want to do our due diligence and ask the question, and maybe talk to a shirt command and say, I know you have HIPAA privilege, I want to talk to you about one of your troops, and they say this is going on. Sounds pretty far-fetched, but is there a way that you can check from your end to see, and heaven forbid it is, what if it is, and this person is telling the truth the whole time, and now we're wanting to slap a psychotic diagnosis on them and put them in a padded room. And they're telling the truth the whole time. Don't do that either. Right? We want to do our due diligence. Persecutory. They're the one being instructed. The patient's the one being instructed toward those long-term goals. Other people are getting in their way. The patient is the one being persecuted. Somatic. Now this one may cross over, but this one involves delusions about somaticism, somatic type. Involves bodily functions or sensations like foul smells that emanate from them, and you don't smell that. Parasites have overtaken my internal organs despite all the tests, labs and labs that you've done. Insects burrowing underneath the skin to lay eggs. Now when might that be true? What condition insects burrow underneath your skin? When you work in bees, you get scabies. Right? And you're already getting the creepy crawlies. Oh, I hate these already. Don't do it. Or you'll see what scabies look like in peas when the fingers and the flexor surfaces, and you say, all right, let me look. See. Okay, sure. Mixed is not one of them, predominates. Unspecified, we can't tell. And then bizarre content is clearly implausible. So not understandable or derived from ordinary experiences. So a stranger has removed my internal organs and replaced them with someone else's organs, and without leaving any wounds or scars. Whoa. All right. I think I saw this in the Matrix when they put that gun on us. No. There's some more subtype examples. There you go. I think I just said all this. Yeah. So there it is in written form. Be able to tell those apart. Be able to tell which one is which. We're talking about delusions, what type? I'm not going to ask you mixed, unspecified, bizarre content's got to be very obvious and pointed, and that's kind of hard to do in a short question. Remember, persecutory, the patient is the... There's the picture types, the 5 main ones that we need to know. If that helps you. What else could it be? Lots of things. What do we do for them? Looks the same, doesn't it? For psychosis, looks the same. Why are we going to give them meds if it's going to resolve in 1 month? That's the definition of delusional disorder. Why are we going to give them meds in 1 month? What are we going to give them meds and they don't even start to work for 1 month? Remember that? Would you? Yeah. What are the chances it's going to happen again? High. Yeah. So yeah, that's why we start treatment in something that's going to be gone in 1 month, because it's not only not guaranteed it's not come back, it's probably going to come back. So that's why we treat it, to protect the patient from themselves and other people. There's our slide again, that Cliff Note slide. Schizophrenia, 2 symptoms. One of those symptoms has to be a what kind of symptom? Positive symptom. Yep. What are those positive symptoms? Hallucinations, delusions, or disorganized speech, except for autistic people. Yeah. And what are the other 2 symptoms? Or what are the other kind of symptoms? Negative symptoms. Yeah. What's an example of a negative symptom? Say again. Apathy. Yep. Withdrawal. Catatonia. Yep. You got it. You know it. It's going through your head. I know it. There's some videos. Y'all have this slide? Good. Take your time if you want to. That's how long each one is on the end. You can watch it. And it's start, maybe give us some mental pictures to help you with what these patients look like whenever they walk through your door or you see them on test. There are some examples of EPS. You look at that. Part of dyskinesia and different types of it. Good. All right, we're going to go through. We got 7 minutes. Look at some of these practice questions. Yeah. All right, first question. All right, what's the question? Most likely, so maybe 1 or more fits. Okay. What's positive? What sticks out to you? Adult or child? Adult. Male or female? Female. Stable or unstable? Stable. Where are we? PCM. Okay. That's the message we're saying. What else sticks out to you? Why is she here? Dyspareunia. What's dyspareunia? What's dis mean? Difficulty with pareunia. Kind of sounds like perineum. Difficulty, painful sex, painful intercourse. That's what dyspareunia is, or medical terminology. So severe dyspareunia, severe pain with intercourse and pelvic pain for 2 years. So what's the first rule of psych? Rule out organic ideology. What are you thinking of when you think of that first? Hopefully. I mean, we're in psych class, we're in psych, but organic ideology, what kind of makes sense that you would want to make sure you test for? STD, yeah. Health inflammatory disease, yeah, exactly. So rule out organic ideology. I'm not going to ask you guys to do. Rule out organic ideology. Good. What else? Well, now we're in psych, and it's starting to sound more like psych. Why is it sounding more like psych? Excessive self-hygiene, multiple remedies tried. So far, that's normal, right? Somebody has this, and I gotta go screaming from rooftops. They're gonna try to fix it themselves. I don't fault them for that, right? What else? Doctor shopping. I hear that. Multiple workouts. What does that tell you? They're concerned. Did they get an answer they liked? Not really. Not enough, anyway. And then what's the next part? It's not working. You give it a workout, not try anything. So what is this question telling you in that part of it right there? Organic ideology has been ruled out by other medical professionals and multiple specialists. You can't find anything. All right, so what lecture are we in? Somatic, yeah. And so when we say has symptoms or doesn't have symptoms, that's the first question we need to ask. Does this person have a somatic symptom? Yes. What is it? Pain. Exactly. They have somatic symptom, pain. Good. Now we got it. What's the second question to ask ourselves? Is it gain or no gain? Is it gain or no gain? What do you think? There's no external gain, obvious external gain. You're not trying to get paid. Hey, will you fill out this worker comp form? And make sure you mark this box and this box. None of that going on. Here are pertinent positives in there. Exam today, lines up with nothing showing. A lot of things to tell you. There's no organic data, no symptoms found. Question?
So I see where the question's going.
Yep.
Everything here though still tells me possible endometriosis.
Okay.
So would you you have to do more of like almost laparoscopic in order to confirm that, right? So it would just be a poor diagnosis at that point, just because that is very common, pelvic pain during intercourse, and literally really nothing we can see from the outside.
I love it. I love where your mind is going. If that were an answer choice, that would be very hard to choose from, right? So you say, this is endometriosis. You're on the pants, you don't get the category, and you say, this is endometriosis. Then you look down there, oh, it's all psych diagnosis. Endometriosis is not an option, and we're not going there. I love where you're going, though. That's ruled out organic radiology, and you may want to think about surgeries and people that don't have it, so you weigh that, right? Is that? What would you do first for endometriosis, just for Charlie's, and way beyond the senior semester? When it's healthy. Put them on an OCP, put them on an oral contraceptive and see if you can regulate that, and if it gets worse then you can rule that out. That's bonus, that's extra, we don't need that for that, but yes, you want to rule out organic data. I love where your mind's going. So good. We look down here, endometriosis. Dang it, it's not one of them. All right, so all we got to do is psych stuff. Love it. All right, what is? Now that's the question. What is, not was or will be, what is most likely the patient's condition? So that's important here too, right? So if you start thinking about this, well, it could have been this, and now she's here, or it's gonna be this if it persists a lot longer. What is? So pay attention to the wording of the question. You know that sounds picky, but answer the question that's asked. All right. Symptoms, no symptoms. Yep. All right. What's A? Illness, anxiety. Do they have symptoms? Illness, anxiety. Does that patient have symptoms? No. That's the worried well. That's the hypochondriac. That's the one who's worried about getting a serious disease. They don't have it now, but what if they get it? Tell them. The well-worried hypochondriacs. So that person does not have symptoms. The one we have today, 33-year-old female, does have symptoms. So that's not illness, anxiety. How about trichotillomania? Does that have symptoms? Yes, it does. What are the symptoms for trichotillomania? Hair loss, right? Hair loss, forehead. Body dysmorphic disorder, does that have symptoms? Does that have tangible symptoms? What do they come in saying? Body dysmorphic disorder. Guys look in the mirror and say, I'm not big enough. The girls say, my nose isn't right. And you go, I don't see it. They say there's a problem, but it's not present. That's body dysmorphic disorder. No symptom present with body dysmorphic disorder. So that's all. Somatic symptom disorder. Does somatic symptom disorder have symptoms? Yes, it does. Okay, we're going to go next. Conversion disorder. Does conversion disorder have symptoms? Yes. What's conversion disorder? Yeah, you can trace it back to a what? An incident, a crisis, conflict. Yep. And then what kind of symptom is conversion disorder symptom? It's got to be voluntary, sensory-motor. Yep, feel or move. Voluntary feeling or move. Right? So that's what, is that what's going on here? pain. Right? It's not voluntary feeling mood. We're back to somatic symptom. So symptom, yes. Pain, yes. Counts, right? Excessive thoughts and feelings about the behaviors. You spend a lot of money, time, doctor shopping, yep. How about persistent high anxiety about the symptoms? The word anxiety, more anxious is in the question, yep. Excessive time and energy devoted to symptoms or health concerns? Yeah, just the fact that she's gone to a lot, spends some money, homeopathic remedies, lots of persistent symptoms. Has this been going on? Yeah, what's the minimum we need? Yeah, 6 months. So we got the time component. Nailed it. Good job, y'all. There it is. At least one symptom, 6 months. Session. And then we'll get the next one next time. Good job. See you tomorrow.